Let me record. Okay. So the most important thing in clinical practice to maintain standards and to maintain your good clinical practice is good medical practice, which is a booklet given out by the GMC. There are 4 domains that you have to qualify when you practice as a physician, particularly in the UK for sure. The first domain is knowledge, skills, performance. The second domain is safety and quality. The third domain is communication, partnership, and teamwork. And the fourth domain is maintaining trust. Whenever you are in an interview or whenever you are in an examination and you're asked a question like, what do you do if a colleague comes to the hospital and he's drunk? Okay, sometimes you're asked these sort of awkward questions. So what is your answer to that question? So these 4 framework is what matters when you give an answer to a question like that. Or what do you do when a colleague is underperforming? Or what do you do if you are unhappy with a certain clinical care pathway that your hospital has? So these 4 domains have to be spoken of. Whenever you give any answer in the exam, you have to always come back to these 4 domains. And whatever you say, you have to talk within the remits of these domains. So let me tell you each one in a little more detail so that you understand what it consists of. Okay, so knowledge, skills, and performance is very well defined. There are a few points in this. First and foremost is you have to make the care of your patient your first concern. So whenever you talk about any non-performing doctor, ill-performing doctor coming to work drunk, it is not about the doctor, it is about the patient. Okay, so whenever you say an answer, you have to say my first concern is the patient, is the safety of the patient. That is the first answer that you have to say. The second point is you have to provide a good standard of practice and care. The third is you have to keep your professional knowledge and skills up to date. The fourth is you have to recognize and work within the limits of your competence. Sometimes if I ask you in an exam, would you do a VATS lobectomy for this patient? And you have only done 3 VATS in your lifetime, then I do not want you to give me an answer that the correct treatment for this patient is VATS lobectomy, because you are not a competent surgeon for VATS lobectomy, but you are a competent surgeon for open thoracotomy. So in the exam, when I ask you, what would you do for this patient? You have to talk about what you would do. And so you have to work within the limits of your competence. That is defined by the GMC very clearly. So that is why I'm putting these points out for you. It's very important. I've sent you the booklet. So go through the booklet, but these are the highlights of the points. Okay. So that is knowledge, skills, and performance. The second domain that GMC talks about is safety and quality. So in safety and quality, there are 2 points that you have to talk about. One is you have to take prompt action if you think that the patient's safety, dignity, or GMC or comfort is being compromised. That's number 1. And number 2, you have to protect and promote the health of the patient and the public. So again, when I ask you a question, if it's a non-performing doctor or somebody who's, coming to work drunk, then you have to say, according to the GMC guidelines, my first responsibility is towards the patient. I have to ensure that the safety and quality of care for the patient is maintained. And it is my responsibility to take prompt action if I think that the patient's safety, dignity, or comfort is being compromised. Do you understand how you have to use these sentences? These are very standard sentences. All of us who are internationally trained, we are used to these sentences. So when you come back to me with this sort of an answer, then I immediately know that you have read the good medical practice guidelines. And so immediately the marking goes very high. Okay. So this is very, very important, what I'm telling you today. Every point that I'm making today is extremely important. It will move you from just pass to a flying pass. Okay, so very important to use these terminologies which I have put on the slide. The third domain which we spoke about is very important: communication, partnership, and teamwork. Treat patients as individual and respect their dignity. This point comes in when we are discussing consent of a patient. And if a patient has refused consent or his family is pushing, saying, no, no, this is the operation that he must have, then you have to say, according to the GMC guidelines, I am supposed to treat patient as an individual. And so the patient's consent is the only thing that matters, not the family's wishes. Do you understand? So this is how you bring this conversation into that. You have to treat patients politely and considerately. You have to respect the patient's right to confidentiality. This is usually, this point, the patient's right to confidentiality, a lot of us actually miss this point. I have spoken earlier about data confidentiality. I have spoken earlier about use of patients' photographs in WhatsApp groups. I have spoken earlier about use of a chest X-ray in a presentation, but not taking away the patient's name and hospital number. So this is directly a this is directly a contradiction of the GMC guidelines. So whenever you do a presentation, it is your responsibility to make sure that you take away all patient identifiers from the chest X-ray or the CT scan. And certainly you cannot share any patient information on a WhatsApp group. So this is how I'm sort of trying to bring it into context, okay? More things about communication partnership is you have to work in partnership with the patient. Any decision that you make has to be in conjunction with the patient. You have to listen to, you have to respond to their concerns and preferences. Again, when we discuss consent, this is the point from the GMC guideline that will come in. Give patients the information they want and need in a way they can understand. So we sometimes, when we talk about consent, we say it should be in the language of the patient. So this is the point which is being covered by the GMC guidelines. Respect patients' right to reach decisions with you about their treatment and care. Support patients in caring for themselves to improve and maintain their health. Work with colleagues in ways that best serve the patient's interest. So any question in an exam which comes about any healthcare problems, your answer should always go back to, I want to serve the patient's interest. And so my decision will be A, B, and C, whatever that may be, okay? So that is the third domain. So remember these the four domains. The third one I've just covered. The fourth one is maintaining trust, okay? And maintaining trust means to be honest and open and act with integrity. Never discriminate unfairly against patients or colleagues. And the last is never abuse your patient's trust in you or the public's trust in you. This question comes in when people talk about having relationships with patients. Once they come to your clinic, you've treated them, and afterwards you go out with them and have an affair, or you marry your patient, or you marry your patient's relative. That is actually a strictly no-no in the medical practice, because when the patient has come to you, he has come to you under duress. He is not in a position of authority. You are in a position of authority. So you are not supposed to take advantage of a patient's, weaker situation. So that is why the GMC very clearly states that you cannot abuse your patient's trust. It's very important, okay? So you cannot have any physical relationship with patients or with patients' relatives, or you continue to text and chat with them. So these are the four domains of the GMC which clearly start with that, okay? So I'm going to again repeat this, particularly for the FRCS exam going people. These four domains are repeatedly discussed in any interviews, in any exams, okay? So I'm going to repeat it. Please take down these four words. Very, very important. Knowledge, skills, performance. That's the first domain. Second is safety and quality. The third domain is communication, partnership, and teamwork. The fourth domain is maintaining trust. Okay, please everybody write these down and remember these, because whenever any discussion happens about an unusual situation, come back to these 4 points and you're safe. Okay, all right. Now, let us come to how we improve the quality of our clinical care. Okay, so now I want somebody. Who is there? Who's doing FRCS exams? Come forward now. Anybody can come forward. I don't mind. Vikas, do you want to start? Are you online with us, Vikas? Vikas, are you there?
Yes, sir. Yes, sir.
Vikas, now tell me, if in the FRCS exam, I ask you, define clinical governance, what are you going to tell me? If you don't know, say, I don't know. We'll move on to
I don't know right now. Yes, sir.
Okay, next person. Anybody else knows what is clinical governance? Okay, nobody knows. So let me just carry on with the lecture.
Systemic analysis.
Yeah, go on. Nikhil, tell me.
Systemic analysis and find out the problem and the technical solution for it.
That is, you're talking about something.
Audit.
Audit, yeah. This is different. So clinical governance, listen to this definition. Okay, this is very important to define clinical governance. If you're going to go into FRCS exam, you cannot pass without knowing what is clinical. So next 5-6 slides are extremely important. Okay, and I want you to write it down. Please write this down with your 200-page notebook. The definition of clinical governance is like this. It is a framework. Okay, that's the first thing. It is a framework in which health organizations are accountable for continuously improving the quality of their services and safeguarding high standards of care by creating an environment in which clinical excellence will flourish. This is an international guidelines. You must, international definition, you must know this. It is and I'll put the whole thing up there. It's a framework through which health organizations are accountable for continuously improving quality of their services and safeguarding high standards of care by creating an environment in which clinical excellence will flourish. Now, you must know this so well that if I wake you up in the middle of the night and shake you and say, give me the definition of clinical governance, you should be able to blurt it out. And that is the level of preparation you need for FRCS. This definition is key. Well, if you're going for an international job or a fellowship, this is one of the standard questions which is asked in an interview. Define clinical governance. And this is the definition we want you to get across to us. Very, very important, these points. So every slide from now onwards, which I'm going to put up, is extremely important, okay? So please write that. This is not in any textbook. This is from the Ministry of Health definitions, okay? All right. Now, I want to ask another question. Anybody knows what are the pillars of clinical governance? I don't mind anybody answering, just give me some pillars. Shilpa, you work in the NHS, you should be able to give me some answers. What are the pillars of clinical governance? There are 7 pillars, you have to name them. It is mandatory if you are talking about quality of medical care. 7 pillars, quickly, give me one name. Any one name, Shilpa. Okay.
I know only
Safety.
So now, the point I'm trying to make, a lot of you know a lot about thoracic surgery, but you know very little about these issues. And that is why these slides are absolutely vital for you, okay? So for clinical governance, there are 7 pillars, okay? The 7 pillars are, I'll tell you. 1, service user, carer, and public involvement. That's 1. Second is risk management. Every word has importance here. The second is risk management. The third is clinical audit. The fourth is staffing and staff management. The fifth is education and training. The sixth is clinical effectiveness. And the seventh is clinical information. Okay. This you have to know. This is 7 pillars of clinical governance. And MCQ can come out of this. Okay. Very clear. And each one of them has significance. Out of this, the ones that I will address are risk management, clinical audit, and clinical effectiveness. Okay. So let's go through these and try to understand what is clinical governance. What do we mean by clinical governance? So this is the picture. If you want, you take a snapshot of this, or when the presentation goes on live on our YouTube, please go through this again. So clinical audit, clinical effectiveness, practice standards, education and teaching, managing risk, systems and processes. Okay, this is very important. This graph is very important. Very few people know this, unfortunately. And so when we sit there and ask you a question, what is clinical governance? Almost everybody looks blank at me. So it is very important to get a flash of this. Okay. And now I'm going to move on to the next one. I'll go through each one of these in a bit more detail. Okay. So anybody knows the definition. What do you mean by clinical effectiveness? What do you mean by, you understand clinical, but what do you mean by it? Anybody knows the definition of clinical effectiveness? Oh, exam going. How many people are FRCS exam going part 1, part 2? This is basics. Okay. It has to be said. Okay. The definition of clinical effectiveness is the application of best knowledge derived from research, clinical experience, and patient preferences to achieve optimal processes and outcomes of care for patient. It's absolutely, this is how we define. So whenever we say a drug is effective or a treatment is effective, this is the definition that is applied to that effectiveness. The application of best knowledge derived from research, clinical experience, and patient preferences to achieve optimum processes and outcomes of care for patients. Okay. You must know these things by heart. I'm sorry, but this is something which is different and you have to know this. So that's the whole definition, how I've put it up for you. Okay. So now this one, I'm hoping that somebody can give me an answer. Okay. So define clinical audit for me. Come on, guys. This is not difficult. Okay. Please define clinical audit. Yeah.
Systemic analysis of a problem, reporting of a problem, analyzing the problem, and find out the solution of that problem to improve the quality care.
Okay, you've got it right, but you're not. Yeah, go on.
Sorry.
Who wants to come in?
Sudhir, sir.
Yeah, go ahead. Go ahead.
I think it's a comparison between what we are practicing and what are the best standards.
Yeah, but if you're sitting with me in an interview across the table and I ask you, if I ask you, please define clinical audit, what would you say? It's not a difficult question. It's a straightforward question. Please define clinical audit. Go ahead. I don't mind you being wrong. It's better to be wrong here than to be wrong in the exam. And particularly FRCS, this will be asked. I promise you.
Systematic
Can
review.
I try?
Yeah,
Systemic
against an set of standards and then implementing change
can I say?
match
okay.
those.
Let me come in with the thing. Okay, I don't think you guys are prepared for this. Okay, so it is a systematic critical analysis. First, you don't say systematic. It is systematic critical analysis of quality of clinical care, including the procedures used for diagnosis and treatment, the use of resources, the resulting outcomes, the quality of life for patients. That is the definition. It must come in this order. This is the Department of Health 1989 definition. And again, I'll put it up. It's systematic critical analysis of quality of clinical care, including the procedures used for diagnosis and treatment, the use of resources, and the resulting outcomes and quality of life for patients. It's surprising. I've got 35, 40 people on this thing, or 50 people, and not even one person knows the definition of clinical audit. And this is the most basic question where the whole Viva starts, okay? So please, it is mandatory. These are the words. You have to come out with these words as it is. There is no two ways about it, okay? All right. So basically, audit is audit of structure, of process, audit of outcome. So whenever you finish the description, the next word that should come. So the moment I say, what is clinical audit? Sir, it's the systematic critical analysis of quality of clinical care, including the procedures used for diagnosis and treatment, the use of resources, and the resulting outcomes and quality of life for patient, which means you do an audit of structure, you do an audit of process, and you do an audit of outcome. This is the answer I expect you to give me in the exam. Okay? Is that all right? Is it getting boring for you guys? Huh?
No, sir.
No.
No, sir.
You have no idea how important this is. No textbook gives you this detail, okay?
Yes, sir. Right.
So this is very important. Everything I put the slides here are something completely out of the textbook. Okay. Now somebody at least tell me the next question, okay? Can somebody, okay, this is the other definition. This is the NICE guidelines definition. I'll just repeat it for you. It's a quality improvement process which improves patient care and outcomes with systematic review of care against explicit standards, the implementation of change. So this is this thing, a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit standards and the implementation of change. Okay, so this is the NICE guideline. So either one of the two you should be able to tell me. Now somebody please tell me, how do you do an audit cycle? Bhushan, you can tell me this. Or Shilpa can tell me, I don't know.
I can take it, sir.
I can try.
Go ahead. Either you take
Yes,
it or
sir.
Vikas take it. Vikas, take it.
Yes, sir.
Come on.
So first you have to identify one problem. What is the problem?
Yes.
Okay.
Then we have to go and study the available data.
Yeah.
Whatever is available, and then we have to set the standards. Then we have to examine our process, whatever process is going on. We have to examine and then compare it with the set standards. Then we have to come out with the results, and we have to suggest the changes, whatever the changes is required. And after that, once we have implemented, we have to re-audit. That is the most important.
Excellent. Excellent. So I like that. So the question is draw the audit cycle, and I'll just flash it to you. It starts with identify problem or issue. Second is set criteria and standards. Third is observe, practice, and collect data. Fourth is compare performance with criteria and standards. Implement the change. And most importantly is re-audit. Whoever is this, please switch off your phone here. We can hear everything that's going on. Okay, is this clear? This is exceedingly important. Even in DNB, even in MCH, this question will be asked. I promise you this. Okay, what is audit cycle? Very, very, very important. Is it clear so far?
Yeah.
I know it is a very boring and an awkward topic, but it has to be covered, unfortunately. Okay, somebody tell me, what are the 3 criteria for risk management? How do you do risk management? Anybody wants to give me a go? Risk management. Have you heard the word risk management? What does it mean?
Sir, it's risk analysis, risk calculation analysis, and then we have to measure the outcome.
Okay. First, what is the definition? The definition is process which aims to help organizations understand, evaluate, and take actions on risks, to increase probability of success and reduce likelihood of failure in achieving objectives. Okay, this I'm flashing it out to you. You have to put it out there. Okay, it's very important. Let me just show it to you again. So this is the definition. Anytime anybody asks you in life, what is risk management? This is the definition you have to give. Risk management is a process which aims to help organizations understand, evaluate, and take actions on risk to increase probability of success and reduce likelihood of failure in achieving objectives. This is the international definition of risk management. Okay, that's number one. The three things that I want to ask you, which I expect you to tell me, what are the pillars or what are the, what are the factors on which you base risk management of a hospital? First is critical incident reporting. Second is dealing with complaints. And the third is risk register. So this answer in an interview has to come out. So whenever I tell you, how do you do risk management of a hospital, you have to talk about these 3 points. Okay. Now we'll deal with each one of them in a little more detail. Very important to understand that. Anybody knows critical incident reporting? How do you do critical incident reporting? Take this question.
I mean, it has to be done in the.
Okay, one person take it.
There is a set form for this in our hospitals.
Yes. So how do you do it? What are you supposed to do?
So there is a critical incident team which actually manages this. So when an incident has happened, you have to fill the form, register it.
Okay, my next question to you, Shilpa, is how many copies are there on this form?
I think, no.
Do you know there are a number of pages behind with different colors?
No.
So how many pages are there? Yeah, so how many pages are there in the form?
So
somebody tell me how many pages?
3 forms and 3 copies. I think.
No. There's only one form, but there are multiple copies behind. So one is the first form, and how many copies behind? And they are different colors.
So one form goes retained to you.
Thank you. Good. Yeah.
Immediate senior. One goes to immediate senior.
Yeah.
Then it goes to the quality team of the hospital.
Yeah.
One goes to the head of the hospital.
Head of the hospital. Yeah. Okay. I'm sort of more or less you're there. Okay. So first one goes to departmental manager, one goes to the risk manager, and one goes to the ward manager. These are the 3 people it has to go. So departmental manager is your head of unit.
Yeah.
Risk manager is the risk manager in the hospital, and ward manager is the person who's looking after that area. Okay. So these are the 3 copies, and 1 copy is retained by you. Very, very, very important. Okay. And this is, and in fact, in the UK, 1 copy goes to NHS England.
Yeah.
To the country's top management. Okay. So in UK, it's 1+4. In India, it's 1+3. So you have to know this. I'm very sorry. It's a very awkward topic, quality management. But these are things which actually make a difference in your clinical practice. Okay. Okay. Is it clear?
Yes, sir.
Yeah.
Yes, sir.
Okay. Okay. Clinical events likelihood. How do you describe a risk chart? So critical events have the following likelihood. Okay. They're defined like this. This is the level of definition. Almost never, unlikely, likely, highly likely, and almost certain. This is the likelihood of a clinical event. The second chart is the impact that it has on the patient, the staff, and the hospital. Insignificant, minor, moderate, severe, or catastrophic. Okay. And then impact is put on the x-axis, and the significance is put on the y-axis, and then you develop what is called as a risk register. So on the x-axis, is the impact, insignificant, minor, moderate, severe, catastrophic. On the y-axis is the likelihood of the event. And whenever an event happens, you give the points, this versus this. So 1, if this is 2, you're 2, and this is 1, then this becomes 2. This is 5 into 5, because this is 5 and this is 5. It's multiplied. So this is 25. And the other important thing to remember about a risk register, that it is color coded. Anything more than 12 gets color coded into red. Anything between 8 and 12 is color coded in orange. And anything between 1 to 6 or 1 to 7 is color coded green. So whenever an incident happens, a critical incident happens, if it falls into the red zone, automatically all alerts are highlighted. And then you get what is called as a serious incident investigation, or serious untoward incident, SUI investigation. SUI investigation. It is mandatory, required by law, required by JCI. Okay, JCI needs this. So it's called as an SUI investigation. Very, very important. Is it making sense what I'm trying to tell you?
Yes, sir.
Yeah, okay. So very important. So risk register is the key thing when you talk about risk management. So whenever I ask you a question in an interview, doctor, what is your understanding of risk management? I want you to first give me a definition of risk management. Then I want you to tell me the 3 things that form risk management are critical events, reporting, dealing with complaints of the patient, and developing a risk register. And then I want you to tell me how a risk register is developed on the x-axis, on the y-axis, and the color coding. And then I want you to tell me that the moment anything falls into red, it sets off all alarms and you end up with an SUI investigation. Is this clear to everybody? Okay. There are various other risk registers in the market. You can use any one of them, but the one which is color coded is the one that is very important, and most people use the color coded. This is another one that you can use where it only goes from 1 to 15, but the color coded one goes from 1 to 25. Your hospital may adapt any one of these. There are many of these, but you just need to know what is the color, how is the color derived, and how the number is derived. The number is derived by multiplying x-axis versus y-axis. It's a multiplication. Okay? Very, very, very important. I promise you this. You might think that I'm talking just a very boring topic or rubbish topic, but I promise you in your clinical practice, these slides that I share today is going to make a huge difference, and also for your exam. Okay, all right. So good. Let's come to, so whoever is there, just shut off your microphone for a second, please. Dr. Mehta, I need to shut you off. Okay. All right. Now consent. Okay. Let's talk about consent. I'm going to, instead of asking you guys, I'm going to go through my slides because I think these are all very important stuff which you need to know. So in a consent, the 5 or 6 basic things that are there, I will put in the slide first. And then I will carry on with multiple slides where I will discuss each and every one of the situation. Okay. And I have sent you the GMC guidelines for consent. I bet you nobody has read it. And that is why I'm going to show it to you. Okay. So the first 5 or 6 important brief synopsis of that guideline is all information needs to be provided to the patient, including risk and benefit discussed. The patient has a right to refuse treatment. Most important. A lot of you forget to say this when you're discussing consent. Frequently occurring life-threatening complications need to be discussed with the patient. Patient can change their mind at any time. The patient has a right to seek a second opinion. Okay, these are the important points which I put out there for you. Now we will go through all of the consent in very, very detail. I'm going to spend a lot of time on this. It's okay if we do this in more detail. So what are the principles of consent? Consent applies to all procedures. all procedures. The moment the patient enters into the hospital, everything has to have the patient's consent, including minor procedures, major procedures, including screening. The patient has to consent for everything that he comes into the hospital for. Nothing can be done without the patient's consent. You have to listen to the patient and respect their views. You have to discuss diagnosis, prognosis, treatment, and care with the patient. You have to share information with the patient, which could be verbal, could be written, or could be a video information. You have to maximize the patient's ability to make a decision. And last but not the least, you have to respect the patient's decision. This is the principle of consent taking. And this is from the guidelines, okay, the GMC guidelines. Every word is very clearly defined, very clearly written down. And I want you to practice this again and again so that it becomes your second nature, okay? So the principle of consent is these 6 points which I've put out to you. Okay, let's carry on. What do you mean by partnership and consent? There should be openness, trust, and good communication between the patient and the surgeon. It has to be customized approach to individual patients. You start by assessing the medical history of the patient. You use the knowledge and the experience of the clinician to decide the treatment modality. You explain the benefits, risks, burdens, side effects of each option, including the option to have no treatment. A lot of people forget this. They forget to tell the patient what will happen if he doesn't have treatment. And in the exam, they forget to tell me that the patient, I have discussed with the patient, option to have no treatment. Patient weighs the option and chooses one. Doctor can choose not to provide that treatment, which means that if a patient has chosen a treatment which, in your opinion, is of risk to the patient or there is going to be harm to the patient, you are not forced to operate on the patient. You have the choice not to provide that treatment, but you have to explain to the patient and document in the notes why you have not chosen to treat the patient. So you can offer the patient to go to another physician, that's okay. But patient has a right to choose whatever is the treatment. But you are not forced to treat the patient if you do not agree with the treatment. Remember this is very important. The last line actually lets you off the hook. It does not mean that anytime a patient comes to you and say, I want treatment, I want you to, so like somebody came to me once and said, I want you to do a robotic sympathectomy for me. I chose not to do a robotic sympathectomy because I didn't think that the benefit of a robot would be worth it to do a robotic sympathectomy. So I sent him away to another surgeon. I said, this is not something that I feel is the correct approach for you. And so I chose not to treat the patient. You understand that? So it is a partnership where both partners have the right to pick and choose. Sharing information in a consent. I think you have to, not I think, I know for sure, you have to talk about diagnosis. You have to talk about prognosis. More importantly, you have to talk about uncertainty of diagnosis. Sometimes you may not be sure about the diagnosis. So you have to talk about uncertainty of diagnosis. You have to talk of all options, including option of do nothing. Very important. You have to discuss the option of do nothing. You have to talk about the risks, benefits, and likelihood of success. In every consent, you have to mention what is the likelihood of success of a procedure. If you are ever doing research, it has to be mentioned very clearly that this treatment is part of research. And more importantly, you have to talk about who is going to be the treating physician. It is the patient's right to know who is the treating physician. So you have to mention in the sharing information in consent. This is straight from the GMC guidelines. Every single point is from the guidelines, okay? So this has to be very clearly drilled into your brains. What about further things? The patient has a right to refuse teaching. He has a right to refuse research. So if you are going to say that my registrar will operate on this patient and I'm going to be teaching him how to do VATS, the patient has a right to refuse it. Or if you are going into a clinic and you're about to examine a patient and you want 3 medical students to come in to observe the examination, you have to take the patient's consent and the patient has a right to refuse. Very important, okay? Patient has a right to second opinion. Extremely important. You should never get offended if a patient says, I want to consult another doctor. In fact, you should be happy, because if you are confident of your decision, then another doctor will actually second your decision. And it makes your decision better rather than worse. So never, ever, ever worry about a patient asking for a second opinion. I strongly encourage, if somebody says, I want to see somebody else, I say, please go ahead and meet somebody else. It is even better because your medical legal practice becomes safer. The patient has a right to know costs. It's very important. It's part of consent. Cost is actually part of consent. You have to tell him all other options of treatment, not just what you are going to do. And most importantly, the patient can change his mind at any time, even on the operating table. Just before you're about to induce, the patient can say, I don't want it done. You have no right to just put the patient under and continue. So the patient can change mind at any time. This is very clearly mentioned in the guidelines, okay? Very clear. So you have to follow these guidelines, okay? Answering questions is mandatory, not just of the patient, but also of the relative. No one can make a consent decision for the patient. A relative cannot make a consent decision for an adult compos mentis patient. When I say compos mentis, somebody who is completely lucid, who is aware of time, space, and person. Nobody, you cannot operate on a patient and then in the middle of the operation decide that, oh, I said lobectomy, but now I want to do pneumonectomy. You cannot go outside and speak to the relatives and get a consent for pneumonectomy and come back in and do a pneumonectomy. You cannot. A patient has the right to decide, and if he has not consented for the procedure, you have to stop. You cannot do a pneumonectomy unless it is life-saving or limb-saving. If it is life-saving, then you are allowed to do that, but afterwards you have to document it and very clearly state why you took the extra step. But again, if the patient has not consented for it, he can actually sue you. That is the reality. Even though you may be trying to save his life, he can actually sue you if he wants to. But most of the times, discussion, open discussion with the patient is the key thing. You cannot withhold any information from patient. Many a times, relatives will come in and say, we do not want you to tell the patient that he's got a diagnosis of cancer. And then they bring the patient in. That is actually not allowed. That is not allowed. You cannot withhold information from the patient about his health. This is mandatory. You have to tell the patient. You don't have to be ruthless about it, but you have to mention to the patient his clinical health before he can sign a consent. I see this very often in India where relatives will come before and they will say, please don't talk about cancer to our father. But the reality is consent is invalid if you haven't told the patient the diagnosis that is there for the patient. If this is done, if you ever have withheld information, you have to very clearly document in the notes why you thought it was important to withhold information. The suggestion across the board is you should not withhold any information from the patient. And again, I stated the patient can change mind at any time, depending upon the information that you've given him. You cannot force a patient to make a mind by withholding information. You cannot give half the information, get him to consent, and then tell him some other things. He is allowed to change his mind, okay? Very, very important. The patient has to be good mental health. Compos mentis is the word, which means he's got to be lucid in space, time, and person. It has to be in the language of the patient. Most importantly, the patient must have time to reflect. In our clinical practices now, almost invariably, we have changed our consent procedure. What we do is we take the consent in the clinic. When we are sitting with the patient, we explain everything. We take the consent of the patient and we give a copy of the consent form to the patient to take home and read through. And then when the patient comes back for the surgery, within 24 hours prior to the surgery, we will repeat the signature of the patient on the consent form to say that he has agreed and he has had time to reflect, and he re-signs the form, and then we go ahead with surgery. Most importantly, for sharing information, it's got to be a balanced approach. You cannot talk of VATS. You have to talk about open surgery. You got to talk about robotics. You got to talk about. I like VATS doesn't mean that the patient needs VATS. This is the most important thing. You've got to have a balanced approach. You must give pros and cons. And if a patient chooses open, you should do open. You should not push your way through for VATS. Or if you don't think that open is right, then you refuse the treatment and send it to somebody else. But it is very important to do a balanced approach. Everything that you do, you have to support your decision with written material. This is required in the UK. We always give the patients leaflets and stuff like that to support whatever you're going to say. And very often, if the patient is not able to comprehend your language, then you can do a consent in the presence of an interpreter. Sometimes the patient is very scared, so you can do a consent in the presence of a patient advocate, which could be a family member, which could be a close friend. But whenever you do anything like this, you have to record that discussion, either written on a paper, or you're allowed to do a video consent, okay? So whatever it is, particularly the more unsure the patient is about the situation, the more is the indication for you to record that discussion, okay? Because patients go back and say, he never told me this, or he never told me that. So it is within your legal rights to ask to record the discussion, and you keep a copy of the record with yourself. And if the patient asks for a copy, you have to give him the copy of the consent process. So that is a requirement. What about patients' families in a consent? What is the role of a patient's families? You have to accommodate the patient's wishes. The bottom line is it's the patient that matters, not the family. If the patient says that I want you to discuss this with my family, then you please discuss with your family, with the family. But the decision is the patient's alone. The patient has to decide, not the father, not the Tauji, not the uncle, nobody. You know, this is an adult patient. There are different situations where family gets involved, but in a normal standard compos mentis patient, the patient decides. Most importantly, sharing information on the patient's well-being is required with the family, provided the patient has consented. You got to remember, sometimes you might have a couple in which they are divorced or they are not together, and you operate on the wife, and then 2 days later the husband says, can you tell me how my wife is doing? You are not obliged. You are actually by law not supposed to disclose the wife's situation to the husband until and unless the wife has told you that it's okay for you to talk with my husband. So it is absolutely mandatory. Sometimes the husband might use the information in his legal case for divorce against the wife. So very important not to share information without the patient's consent. However, it is highly recommended that you must talk to the family about the patient's well-being, but usually try to do it with the consent of the patient. Is it making sense, guys, or is it getting too much?
Perfectly making sense, sir.
Perfect.
Yeah, it is very important. All
Very
of this.
difficult.
I'm sorry, I'm taking more detailed time, but it is very important. You won't get this coverage anywhere else. What are the obstacles to sharing information in a consent? Okay. So the obstacles to sharing information could be time. It could be that you're very busy. and you're really struggling and the patient is asking a lot of questions and things are getting very difficult. It could be resources, as in you don't have the literature available and things like that, or you don't have a room available where you can sit down with the patient. It could be, the thing with consent is that you can delegate a consent. You're allowed for somebody else to take a consent, but the responsibility of that consent is always yours. Always yours. If you do delegate, I'll talk about that in a minute. Whenever you do consent, you have to also take into disability requirements. Okay, some people may be short of hearing, some people may be on a wheelchair, things like that. Some people may not be able to understand the language. So all these barriers you have to actually overcome to make sure that the patient's needs are met. Okay, and if any of this happens, the first four, you have to raise an issue with the organization so that there is no barrier to a good informed consent. Okay, so responsibility of seeking consent, it is your responsibility, full stop. If something goes wrong, at the end of the day, you are the one who is answerable. You cannot say that my registrar forgot to tell him this. Bottom line is, it's your responsibility. You can delegate, you're allowed to delegate, but the responsibility is yours. But when you delegate, you have to make sure that the person who's going to do the consent is suitably qualified, has sufficient knowledge of procedures and risks involved with the procedure, i.e. somebody who has done the procedure before. And third, but not the least, is somebody who agrees with the guidelines of the GMC. Okay, so this is the requirement of who you can delegate to. You cannot delegate to somebody who's not a doctor. Well, the last point is saying that he should be governed by the medical council. So you cannot delegate to your healthcare assistant to take a consent. A lot of you, I know this for a fact, I've seen it in my hospital, in India I'm talking about, not in the UK. A lot of you ask the nurse to get patient se sign kara lo, get the patient to sign the consent. That is not allowed. That is NOT, not allowed, because that nurse is not governed by the medical council guidelines. She's governed by a nursing council guideline. So only person who can take consent is a doctor who is governed by the medical council guidelines. Absolutely clearly written in the guidelines, very clear. So a nurse taking a consent is not a valid consent. It is in fact an invalid consent. Okay, very, very, very important to understand this. What are the risks of consents? What are the risks that you need to discuss with the patient? You have to discuss side effects of treatments or drugs that you're going to do. You're going to talk about complications, common complications that can happen with an operation. More importantly, you have to talk about failure of intervention to achieve a desired effect, which means that if you're doing a pleurectomy for a bulla or a pneumothorax, you have to talk that your pleurectomy may not be effective. Or if you're doing talc, you have to talk about the talc may not be effective in 5% of patients or in 1% of patients, whatever. You have to talk about failure of intervention to achieve the desired effect. You have to talk about outcome of no action. See, everywhere the guideline is repeatedly saying that you have to talk about what will you do if you don't do anything. So very important in the consent. You have to talk about the risk of permanent disability and death. This definitely has to be mentioned. Okay, this definitely has to be mentioned. And you have to talk about any serious adverse outcomes. Okay, so there is, the guidelines do not talk about what should be the percentage of any of these. Most of us have an understanding that it should be more than 1%, which you should mention in a consent. But actually the guidelines have not spoken about that 1%. They say anything that can cause permanent disability, death, or serious adverse outcome has to be discussed with the patient. Okay, all right. Now, making decisions in a consent, do not exceed the scope of your decision except in an emergency. Mandatory. Do not think that you can open the abdomen and do whatever you like or things like that. It is not. You have to know what is the scope of your decision, what the patient has told you. And if you think it doesn't need to be done, you just come out, wake the patient up. Do not do anything more than what is needed except in an emergency. And emergencies are only two: life-saving, limb-saving. Okay? So very, very, very important. Very clearly stated. These are guidelines very clearly stated. Do not exceed the scope of your decision except in an emergency. When you're making decisions, you must also discuss future events with the patient so that if something changes, then you can change the consent because you have discussed with the patient. Ensure the decision is voluntary. The patient's decision is voluntary. Particularly when you're dealing with family putting pressure on the patient, or a patient is in a care home, or there is issue of mental health with the patient, or a patient is an immigrant under immigration detention and he's being pushed into having something done, or a patient is in prison. Very important, particularly when you get immigration and prison issues, get all your sensors up to make sure that the decision is voluntary. Okay, you have to respect the patient's decision. That's the bottom line. All right. Okay. The expression of consent can be in writing, but oral consent is also allowed, but you have to record the oral consent in notes. Okay. Implied consent is also allowed, which means that for minor procedures, which means that if you want to take blood pressure of a patient and he pulls up his cuff, his sleeves, then it's an implied consent. But implied consent usually is only for minor things you can do it, not for major things. Oral consent also is for minor things, not for major things. Okay. So for minor cases, you can do oral or implied consent, but for a high risk or any major procedure, it has to be a written consent. Okay. Very important. Particularly when you're dealing with fertility issues. There is no two ways about it. In a fertility issue, it is so litigious, so medico-legally sensitive that GMC has actually written in the guidelines. Whenever it's a fertility issue, you must have it in writing. And usually it is the consent of the person undergoing the procedure, not the spouse. Spouse does not have to agree. Or if the spouse disagrees, it doesn't matter. It is the person's body. She can decide what she wants, or it's his body, he can decide. So if you're talking about a vasectomy or a tubal ligation, if the wife wants to have a tubal ligation and the husband says no, she must have a tubal ligation because it's her decision. If a husband does not want to have a vasectomy and the wife says you must have in the consent, it is the husband's decision that matters. So very important. Fertility is a very sensitive topic. And most importantly, when you're dealing with high risk, when a consent is going to affect employment, when a consent involves research, or a consent involves innovation or a new technique, it has to be written. There is no role for oral or implied consent in these four situations. Okay, very clear cut. Again, from the guidelines, from that book that I sent you, which you did not read. It is important to record consent. It is important to review a consent. Consents can change with time. Situations may change. Decisions may change. Newer information may come into being. And if any of that has happened, then you must review the consent, and the patient has a right to change his decision if some new information has come to the front. Okay. So if significant time has passed, you must review consent. If there is a change in the patient's condition, then a consent given before is not valid. And if new information is available, then a consent given before is not valid. These are the 3 points where you have to review consent. Okay. Very, very clear cut. Okay. So far, so good. Is everybody clear on this?
Yes, sir.
Yes.
Yes, sir. Yes, sir.
Are you guys bored or not bored as yet?
Not
No,
board.
sir, not at all.
M-O-T. Not board, sir.
Not bored. Okay. Now these are all very important issues. Okay. So let's get on to the next one. This is the most difficult one. Okay. Children and young patients. Children is okay, but it is the young patients that is very difficult. So let's talk about children and young patients. Whenever you take a consent, the view of the child has to be taken into consideration. This is the first line in the GMC guidelines. They say that you cannot, the parents cannot alone decide. If the child has a certain view, you have to take that into consideration when you are doing consent. The views of the parents have to be taken into consideration when it's a young child. The views of others close to the child, in the sense that it could be a healthcare worker, or it could be a social worker, or it could be a grandparent, all their views have to be taken in, particularly when you're dealing with children. It is also important to take in the cultural, religious, and other beliefs of a child and the parent when you are consenting a young child. Views of other healthcare workers who have an interest in the benefit of the child has to be taken in, particularly if this child is in social care and taken away from the parents and things like that, then healthcare workers become involved in this. So you still need parents' consent, but healthcare workers' views are taken in when you are deciding if the consent is valid or not valid. And most importantly, it is the choice which will least restrict the child's future options. Okay, you have to decide as a clinician that the choice which they make will least restrict the child's future options. This is the guidelines of a child in the GMC. Okay, very clear cut. The parents and carers are involved. One parent is sufficient to give a consent. You don't need father and mother. Only one parent can give a consent. But if there is dispute between the two parents, then you have to involve the court. It has to go to court, and the court will take the decision for the child. You and another physician cannot take this decision. It has to go to the court. Whenever there is medico-legal dispute, or whenever there is legal dispute between parents, the court has to be involved, and the court will take the decision. Very important to involve children, and particularly young persons who are 14 and above is very important. There are two groups. One is above 16, there is a different thing. One is below 16, but who are deemed to be able to give consent. And we'll talk about that in a minute, but very important, okay? At 16, the child is able to make own consent, and they can overrule the parents. There is no issue with that. And less than 16 also may be able to make own consent, particularly when we are talking about things like contraception, we're talking about sex issues, sex education, things like that, okay? So remember, there is no law which says that somebody who is 14 years old cannot decide about contraception, okay? So very important. You must know these things. All right. What about young patients with capacity? They are allowed to choose their own things. They are not forced by the parents. A parent cannot override a competent young person. Most important. You have to weigh the pros and cons of the refusal. Okay, why are they allowed? So a parent may say that I want this patient to have this operation, but the child will say, I don't want to have it. And he is a competent young person. Then you are allowed to weigh the pros and cons of the child's refusal, okay? If you're worried about it, and if you think that the refusal is going to affect the clinical outcome for the person, then you must seek legal advice. And if you are unable to resolve the dispute at that stage, even with your hospital's legal advice, then you apply to the court to resolve dispute. So you don't jump into the court straight away. So these are situations where there's a fight between two parents, or there's a fight between the child and the parent. And these are all tricky things. So these are clearly documented within the guidelines of what you have to do. And this is the step-by-step way of doing it, okay? All right. Particular issue comes in when we are talking about contraception, we're talking about abortion, and we're talking about sexually transmitted infections, okay? So if the young patient understands the implications, he is actually allowed to choose without parental knowledge and consent. If you have given contraceptive advice to somebody who is 16, you do not have to call his parents and tell them that, look, your daughter is asking me for contraceptive pills. You're not. You do not have a legal obligation to do that. You are allowed to go. The bottom line, what you have to decide is, if you tell the parents or don't tell the parents, the bottom line you have to decide is, they will choose to have sex with or without the treatment. And so it is a much worse for the patient not to have the treatment. And that is why you are allowed to actually give them the option to choose without informing the parents. Also, you're allowed to choose if the physical and mental health of that person will suffer. And you're allowed to do it if it is in the best interest of that young person. Okay? So more than 16, definitely. Less than 16, you have to make an assessment whether is he competent enough to do to give a consent, and then accordingly you decide. If you feel he's competent enough, you can do that, or you take legal advice, or you go to court. It's okay to do any of them. So this is where the concept of Gillick consent comes in. It is from this last slide which I told you about contraception. Okay, so Gillick consent was a case between Mrs. Gillick and the health authority, where she objected to the health authority giving contraceptive advice to her daughter, who was already sexually active. Her daughter was less than 16. She was sexually active, but she chose to have contraceptive advice from the health authorities. And the court ruled that you are allowed to give contraceptive advice to the young girl because she's going to have sex whether you like it or not. It is going to harm her health in the sense she could get pregnant. So the health authority were actually relieved by the court and said that it is okay to give contraceptive advice to the girl because she was deemed to be of mature age who could make a decision for herself. So Gillick consent is usually asked in the exam. Okay. All right. What about capacity issues? We're talking about mental health capacities. What if a patient is not, full compos mentis? What do you do in those things? You have to, in India, you have to use the Mental Health Act. I don't remember what is the IPC for it. But in the UK, it is the 2005 Mental Health Act. In Scotland, it is the 2000 Mental Health Act. Adults with incapacity. These are the two. In India, I don't know what is the IPC. You'll have to check that out. So you have to make a patient assessment. You have to get nurses and others involved who are close to the patient. A psychiatrist, a neurologist, or a speech and language therapist, particularly for patients who are on ventilators, who are not doing well, or who are pretty, in the ICU and things like that. Then these are the three people you have to get involved. You have to resolve disagreement among the various groups. If you are not sure that there is agreement amongst all the people involved, then you take legal advice or you actually apply to court. Okay. So this is the law. This is the pathway. But you can treat without consent if it's an emergency. That's the bottom line. You can treat to save life or to prevent serious deterioration. And this is again clearly stated out. So legally, you are covered by the law. So I'll just go through a few legal cases now. Okay. Did this make sense? Anybody's got any questions on this? This is quite a hot topic, so I need to make sure you've understood.
Perfectly well said.
Perfect.
Okay, so let's carry on. Okay. All right. Now I'll just show you a few cases. These are UK cases. Obviously, in India, you'll need to look for Indian cases. As I go along, I'll tell you about some Indian cases, but these are the UK cases. So this was a case of Chester versus Afshar. The duty to warn patient about risk. This is very clear. It is your responsibility to discuss risks with the patient. This was a case related to a patient who underwent a lumbar disc surgery, and following the lumbar disc surgery, she had paralysis. And the treating orthopedic surgeon had not discussed in detail or not told the patient about the risk of having paralysis. And so he obviously lost the case, but this became within the consent protocol that the duty is important to warn the patient about risk. A similar case happened in India, where a cardiothoracic surgeon took a patient with a posterior mediastinal tumor, which had a little bit of dumbbell into the spinal canal. Not clearly going into the spinal canal, but had some evidence of the tumor going into the spinal canal. And he decided that he was going to operate. He must have explained to the patient the risk of paraplegia or whatever, but he did not have in theater a neurosurgeon present. And so the patient unfortunately developed paraplegia when he tried to take out the little portion of the tumor which was in the canal, because that is dangerous. What happens is you use diathermy in that area. The diathermy has expanded field, so the heat goes into the canal. And so unfortunately this patient had paraplegia, and he went to court. And actually in the court, the cardiothoracic surgeon was held liable because he did not have a neurosurgeon stand by in theater for clearly evidence of intraspinal invasion. So it is very important that you mention it's a duty to warn the patient about risk, and you have to make sure that you do not do anything that is beyond the remit of your specialty. Okay, very often I know people who go into the neck and try to take out a lymph node in the neck. A thoracic surgeon trying to take out a lymph node in the neck. Nowadays, if you're in a small town, it's different where you don't have specialty available. But if you're in a big hospital where there is a head and neck surgeon available, you have no business to jump into the neck. It is not your specialty. So very important to understand that. The second case which the guideline talks about is the right of a competent adult to refuse medical treatment. Okay. More so for mentally ill patient as well. Just because a patient is mentally ill does not mean that he does not have capacity to give consent. This is very important. If a guy's got schizophrenia, so what? It doesn't mean that the family will decide for him. He can still decide for himself. He still may be compos mentis to make a decision for himself. So this was about a paranoid schizophrenic patient who had limb gangrene and who was not agreeable to surgery. And eventually the court said that you cannot force him to have surgery because though he's got schizophrenia, he's not incapacitated to give consent. He still understands his time, space, and person orientation. And so his consent is valid, not the consent of the doctor and not the consent of the treating paramedic, treating family members, okay? So very important to remember that just because a patient has diagnosis of depression, anxiety, schizophrenia, something like that, you cannot impose the consent of the father or mother on the child. You cannot. You got to be very careful about it. Okay, this is the other case, capacity to refuse treatment. This was about a patient who had a cesarean section. This was about a patient who was needle phobic, and she was in for delivery, and she refused a needle section. She refused a C-section, and eventually it went to court, and the court says you cannot force a lady to have a C-section. It is her decision. Whatever is the reason, it is her decision whether she wants to have a C-section or have it by normal delivery. And so the clinician's concern was overruled and the patient's decision was decided. This is about right of a patient to who has capacity to refuse life-prolonging treatment. This is another situation we are often dealt with. This was a tetraplegic on an artificial ventilator, and she did not want any further treatment. She was with it. She understood all the things, and the doctors were not happy to wean off the treatment. Doctors were saying, we cannot wean off the treatment. And the patient was saying, I do not want you to continue treatment. And so eventually it went to court and it said, a patient who has capacity can refuse life-prolonging treatment, very, very clearly. And living will is also to be respected. If the patient has previously said that I do not want to be ventilated in writing, then you should not, no matter what the situation, no matter how much the family pressurize you. The family may say, no, my father, I want to give him a chance, etc., etc. But once the patient has made a living will, he has written that he does not want to be ventilated, You cannot ventilate the patient, full stop. Okay, all right. This is another case of the right of a competent pregnant woman to refuse treatment, even if that refusal may result in harm to her or her unborn child. So this was in relation to the mental health application. In this one, the patient was pre-eclamptic, but she was refusing to have a C-section or a medical treatment. The doctors were saying she should have the medical treatment, otherwise the baby will be affected. And she was refusing to have a medical treatment. And the court ruled that the baby's life consent is not the mother's responsibility, in the sense that if the mother is refusing treatment, you have to go with what the mother wants. You cannot take a consent, you cannot force a consent onto the mother because the baby is compromised. You understand that? So that was this case. Very clear cut, they said that an unborn child does not have the right to consent. It is the mother who has the right to consent. And you cannot force a mother to have a C-section to save the baby. I think this is the last one. The effect of coercion or pressure on a patient's consent. We see this in India so many times, where the son pushes the old father saying, have the operation, or the mother pushes the son to have the operation. It is not allowed, okay? This was a case where a young lady was refusing blood transfusion because her mother was a Jehovah's Witness. Jehovah's Witness is a sect of Christianity who do not take blood transfusion. But the daughter was not a Jehovah's Witness, and she was an adult. She was not a Jehovah's Witness. And so the doctors applied to the court saying that the daughter is making a decision under the pressure of the mother. And so the court said that you have to give her blood transfusion if it is life-saving. The mother's religious sentiments do not matter in this situation. Okay, all right. So did this make sense now? So far, so good? I'm happy to stop and ask questions, because consent is a very, very important issue.
It's going good.
Got anything hot which they want to ask? Or you want to wait till the end?
Till the end.
Yes, sir.
Okay, wait till the end. Okay, so it's important. These slides are gold mine. Okay, so please listen to them carefully. Even the next section which I'm going to do is exceedingly important. A lot of it you already know, but you are not able to express it in the way it is supposed to come in an exam or in your clinical practice. Okay, so I have put it all point-wise very clearly for you to follow. Okay, so let's get to the next topic. This is very important. This is called as NATSIP. Okay, NATSIP and LOCSIP. NATSIP is National Safety Standards for Invasive Procedures. Shilpa, you must know this. I'm doing this. When you get time, please download these NATSIPs and LOCSIPs. It's very important in the UK. But it's also applied in all hospitals which have JCI or NABH accreditation. So it's exceedingly important, okay? All right. So a lot of us see these videos, you know, read these papers which talk about catastrophic intraoperative complications, okay? It's really, you'll be surprised. Anything that should not happen has happened. And you'll be surprised when you read these papers that how could this have happened? How could this have happened? And the reality is it happens because people do not follow the safety guidelines for invasive procedures. There are certain standards set across the world, and they have to be followed. If you follow those guidelines, then these sort of disasters will not happen. So what sort of disasters? In medical harm, you have what is called as near miss. You have what is called as adverse event. You have what is called as errors, act of commission, that means doing something which caused a medical harm. You have act of omission, which means not doing something which caused a medical harm, and a never event. This is the sort of 4 or 5 things that you need to know. Whenever a patient has medical harm, one of these has happened, and that is why patient has had medical harm. Okay, if you look at the whole literature and things like that, The number of never events. Never events are something that should never ever happen. Never ever happen in medical practice. But they are very well reported. Okay. And over the years, these numbers are going up. Unfortunately, they are not going down. They are actually going up. And so that's why these things are important. And that's why the guidelines are important. So what are the never events that I have come across in thoracic surgery? Now, I have not done these, okay? But I have been expert witness in a few of these situations. So I'll tell you what has happened. And you'll be shocked when you hear this. A wrong side operated. The lesion was on the right side. The surgeon operated on the left side, okay? Wrong side operated. Extra side operated. The consent was chest. The patient also did abdomen. The consent was chest. The patient consented for chest. The surgeon did the neck in addition to the chest. Wrong lobe resected. The tumor was in the upper lobe and the surgeon took out the lower lobe. Extra lobe resected. The consent was for a right lower lobectomy and the surgeon did a bilobectomy. A patient had a lobectomy and no lesion was found because the CT was old, more than 6 weeks old. Okay, so he came in with a tumor in the lung, whatever, with a mass in the lung, and the surgeon did not bother repeating the CT and went ahead and did the lobectomy. And unfortunately, it was an infective mass. And when the lobe came out, there was no lesion. A normal lobe was taken out. Lobectomy for a nodule, which got reported as TB. And the patient sued the surgeon because you're not supposed to resect, you're not supposed to do a lobectomy for tuberculosis, for a simple nodule. And unfortunately, the surgeon lost the case. Okay. Traction injury to nerves, positioning of the patient, very important. Brachial plexus injury, injury to the ulnar nerve, injury to the median nerve because of positioning, lateral position on the table. Wrong consent, which means the patient is having one operation and a nurse took the consent and wrote something else and nobody checked the consent. And even worse is that you operated on the patient and eventually it turned out that there was no consent form signed. Okay, all of these are cases. These are real life cases where I have given expert witness, okay, in these situations. And it is very, very, very distressing for the surgeon, distressing for the patient, distressing for the hospital, and distressing for the society. That is why my talk, which is going to follow, is extremely important, because you want to avoid any of these scenarios in your lifetime. You never want to be involved in any one of these clinical situations, which I've just told you about, okay? So let's look at what happens. One more specimen, this I was involved with, a pathology specimen got thrown away in the bin. Okay, we did a lobectomy, took the lobe out, and the circulating nurse did not realize that the lobe which has come out has to be put into a pathology jar and has to go for histopathology. He put it in a bin and threw the specimen out, okay? Retained foreign bodies. You operate in the chest and you leave something behind. Guide wires, catheters, bag, Alexis retractor, metallic screw. Whenever you use an instrument, the responsibility is yours. If a screw falls out from that instrument, you cannot say that it is not my fault, it is the manufacturer's fault. Unfortunately, the patient will blame you, and it is your responsibility in the court of law. And then you have to defend yourself why a screw or a piece of metal snapped from that instrument and was left behind in the patient. It's really, really dangerous. Everything comes back to the surgeon. So you got to be very careful about it, okay? And these are all real life examples. These are not made up examples, okay? There's a swab there, okay? Post CABG, there's a swab there. Okay, here there's some foreign body here left behind and some foreign body left in the subcutaneous tissue as well, okay? some sort of I don't know what it is, some instrument left behind. So JCI has looked at it, and these are the number of events that are reported, okay, up until 2012. I don't have the latest figures, but these numbers are going up according to the this thing. So the important thing is around what you got to realize is 10% of surgical patients have this problem. It may be minor, but around 10%. So 1 in 10 patients that you operate actually gets a harm because you didn't do something right. Okay, so that's shocking. 1 in 10 patients that you are operating, every single person whom we are operating actually is getting a minor harm. Okay, so it's very important. It's very expensive because medical legal claims, payout to the patient, payout to the society, our insurance goes up, and the whole thing. It's an extremely expensive problem when you make a mistake in the patient. Okay, so that is why NATSIPs are mandatory. There is no two ways about it. Not even 1 point on these slides can be overlooked. Nothing. Everything that I say from now onwards has to be done. There is no excuse for not doing it. No matter how long, no matter how much time consuming, it has to be done. Okay, so NHS England in 2015 came up with NATSIPs based on the harms that they did. So they created a system to prevent harm to the patient. Okay, they have recommended that everything that we do has to go through multidisciplinary teams. No one person can take a decision. Even if you're doing a CABG, it's supposed to go through a cardiologist and a surgeon and a radiologist involved. So it is very important that every decision is made through multidisciplinary teams. There have to be local safety standards for invasive procedures called as LOCSIPs. So in addition to national safety standards, every single hospital will have their own LOCSIPs, okay? And it's very, very, very important. So let's look at NATSIPs, okay? So NATSIPs are of 2 types, okay? One is organizational, that means they're addressing the organization. And the second is sequential, okay? So I'll talk about this in detail, so don't worry about it. All right, now please take these notes down, okay? These are very vital, okay? What are the organizational NATSIPs? The first and foremost point in the NATSIP is governance and audit. And my concern is when I asked all of you the definition of governance, nobody knew the definition of clinical governance. And when I asked you what is the definition of audit, you were struggling to give me a definition of audit. And that is the first point in NATSIP. Okay, the first point they've mentioned is governance and audits. So please realize that when you're going to do medical practice, you have to make sure it is safe for you, safe for the patient, safe for the hospital, safe for society. That is why it is mandatory to understand what is clinical governance and audit. Okay, now let's talk about it. A safety culture and system that is proactive and reactive. That is the bottom line they have said in the NATSIP. Okay, so these are the guidelines that have been placed for governance and audit, and I will go through each one of them in detail. Okay, so first and foremost is there should be visible governance in the hospital, and more importantly, there has to be clear leadership. So we're talking about organizational NATSIPs, okay? So in the hospital, there should be clear governance and there should be clear leadership. Clinical improvement meetings are mandatory. Anything that you do, there should be M&Ms and there should be teachings and stuff like that. All incidents have to be managed. Critical incidents have to get clear-cut guidelines of how to manage a critical incident. Particularly serious incidents. Serious incidents have to be managed, and there is a concept called as SMART. Okay, write this down. SMART is for specific, measurable, achievable, relevant, and time specific. So all serious incidents have to be specific. They have to be, you should measure the harm that is done. It should be achievable. Whatever guidelines you put in should be achievable. It should be relevant to your clinical practice, and it should be time bound. There has to be a time limit within which you must do these things. Okay, so very important. You must have a system in place in the hospital for management of patient concerns, compliments, and complaints. So everything should. So in our this thing, we have a patient officer who deals with all of this. We have an appointed guy who is a patient's officer, whom they go to whenever they have any issues for the patient. The hospital is supposed to have standard guidelines, standards, policies, and protocols, mandatory. It should be written down. There should be a file available for everybody. The risk management has to be clearly defined. The risk management strategy has to be clearly defined. All doctors, medical staff, paramedical staff have to undergo induction. You cannot start working in an organization until and unless you have been inducted. Okay, very important. And I'll talk about induction a bit later. And anything and everything that an organization does has to be based on clinical effectiveness. And that is why I threw the definition of clinical effectiveness at you. Okay, so very important. Remember, 3 of the 4 of the things are mentioned here: clinical governance, audit, and clinical effectiveness. This is part of national safety standards. Mandatory, an organization must have these 3 in place. Okay, let's look at the next point for organizations. Documentation of invasive procedures. The philosophy is, if it is not documented, it did not happen. Full stop. There is no 2 ways. You know, I spoke to the patient, he talked to me, he this, he that, nothing. If it is not documented, it did not happen, bottom line. Okay, so let's look at the documentations. What is needed for documentation? The documentation has to be standardized documents. You cannot have one for neurosurgery, one for thoracic. Everything has to be standardized through the hospital so that when the patient's pathway crosses departments, people do not get confused with different documentation. It's got to be one set of documents. It's got to be a standardized document. And the design of the document should be such that it continues through the journey of the patient through the hospital. It has to be designed in such a way. You should not have separate things for separate departments. Whatever you do has to be complete, legible. No contemporaneous effects should be seen. No abbreviations, and standard terminologies have to be used. Okay, very important. This is very clear cut and very important. Whenever you're doing an invasive procedure, it must include pre-procedure assessment, a pre-procedure planning, a plan for anesthesia and sedation. The consent must include the risk. A preoperative checklist should be there. Conduct of anesthesia should be mentioned. The team members that were present has to be documented. The sequential following of lock sips, we'll do that in a minute. We'll talk about lock sips in a minute. The operation notes have to be documented, and post-procedure handover has to be documented. Now, all this you do every day, but very often you forget a lot of these things. And unfortunately, you are actually not allowed to forget any of these steps. You have to make sure that every single step of this is actually documented. Okay. The time that you did this, the time that you signed it has to be documented. So it just has to be dated and time, and the name of the person has to be clearly legible. You cannot, scribble your name. You have to write your name very clearly. If ever there has been an adverse event, Datix is a system of recording adverse events in the UK. Your hospital may have their own system, but you must have a recording of adverse events, near miss, unexpected outcomes, and most important, the paper and the electronic system should be aligned. As far as possible, everything should be electronic. That is the recommendation nowadays. Paper is going out of fashion. Most people are now asking for electronic documentation so that there is no duplication of effort, energy, and time. Okay, so this is it. Is it making sense, guys? So far, so good, or is it getting to be too much? Hello?
Perfect, sir.
No, sir. Perfect, sir.
Are you still with me?
Yes.
Yes, sir.
Yes, sir.
Okay. All right. I'm sorry, it's a very boring, dry topic, but this is what will save your life.
No,
okay.
it is not
No,
at all
sir.
boring.
Okay.
Sir,
all right.
one medico-legal case.
Yeah,
been
we'll destroy
vandalized.
your career. We'll destroy your career. Absolutely. Okay. All right. Let's look at workforce. There should be safe staffing at all times. You cannot do it with no circulating nurse present or no ODA present, no GDA present and things like that, okay? All workforce there's a certain threshold that has to be achieved for doing anything. You must make sure that the staffing is safe, and unfortunately it's the responsibility of the operating surgeon. So you have to make sure that there is adequate there's adequate workforce that is safe to operate at all times, okay? So let me go through each one of this in more details. The philosophy is no staff, no start. You cannot say that aa jayega wo GDA ko bulaya hai, ye hai wo. Those are not acceptable. You cannot wait for somebody to come. No staff, no start. You have to wait till the whole team is there. That is when you can start doing an operation. The patient must have day and night cover, mandatory. These are written down laws, okay? There is no two ways about it. Whenever you make an operation or schedule, you must give sufficient time for the operation. No point putting 10 cases together in an 8-hour list, and each case is 2 hours long, okay? So sufficient time has to be given for the staff to do the procedure, and also for the instruments to be turned over and things like that. So you cannot rush the team into doing the next case. You have to make sure the workforce has sufficient time to do whatever they're needed to do. And sufficient staff is available. Allocation risk is managed to make sure that you don't miss out on anything. Make sure that you have a backup plan in case, say you took a patient at 10 o'clock in the night, an elective case at 10 o'clock in the night to the theater, and suddenly you had an emergency come in with a stab knife in the A&E. Then you have to make sure that there is backup for the emergency to go to another theater. So that is what they're talking about, surge management, because it's like surge pricing. Sometimes the demand goes up and you have to make sure that there's enough staff available for the increased demand that is needed. All workforce has to undergo regular trainings. In the UK, everybody has to do what is called a stat and man, statutory and mandatory training. You cannot get your appraisal without stat and man, okay? So mandatory. Any trainee or any student is not allowed to do anything on their own. They have to be supervised. It is within the guidelines. They are not allowed to do things on their own. They have to be supervised. And escalation process has to be there. If you are worried that somebody is not performing well, or if you are worried that a patient's care is being compromised, there has to be a system in place in the organization where that worry can be escalated. It should not be a blame culture, but always the focus should be patient safety. That's the most important thing, okay? All right, what about your operating list scheduling? How do you manage that? Very clearly they have said, a planned list with clear information enables safe care. That's the philosophy. So let's look at that, okay? Key patient and procedural information is mandatory in an operating list. Workload has to be managed according to time. You cannot keep more patients and then hope that some get done and then cancel something, or then extend the operating list to way beyond. Elective work should not be done in emergency time. That is the philosophy in the UK, okay? The scheduling, there should be a standard operating procedure for how you schedule a case on an operating list. Okay, so this all is there, and I'll go through it in more detail. So the operator has to be clearly defined. Surgeon's name has to be clearly defined. For a patient, these things have to be mentioned on there. Name, number, date of birth, gender, planned procedure, the site and the side is very important. So left thoracotomy, source from where the patient is coming. Either he's coming from the ward or ICU or 2B, 3A, 4C. You have to clearly mention that, okay? It's mandatory. The laterality has to be mentioned, not R and L. You have to write right and left. You're not allowed to write R in a circle. Not allowed. It's illegal and it is an actionable offense. You could be sacked if you did that. That is called as act of commission, okay? Where you write R with a circle, because R could be misunderstood as L. Some people's writing is different. So you have to write right or left. You have to write significant information, which means how urgent is the case? Is it elective, urgent? What are the comorbidities which will affect the outcome? So, you know, if the patient has, say, he's on dialysis, then on the operating list, that information must appear. That this guy is for CABG. Ahead, it should say, in another column, it should say, will need post-op dialysis. This has to be mentioned in the operating list. No abbreviation at all. CABG is actually not acceptable. It is not acceptable. There is no such thing called a standard abbreviation. On a list that is typed, you have to fill in everything quite clearly. If you have an incorrect list, which means it came to theater, the patient came, and then, you know, another patient suddenly turned up, then that becomes an incident. And so you have to fill in an incident form if an incorrect list comes to theater, okay? The order of the list is decided on clinical priority, not on surgical priority or surgeon's priority. It's decided on clinical priority, very clear cut. The day case is always done first on the list, very important. If there is any order change, if you had to change the order, then there has to be a reason why you change the order. Either because of clinical priority has changed, or because there are some safety issues like a tuberculosis, open TB, you will want to do last on the list. So things like that have to be very clearly documented. The list has to be recorded, the reordered list. If you've changed any order, then you have to reprint the list. You cannot write with your hand the changes. That is not allowed, because a lot of mistakes are done when you forget to write in all the lists that were there in theater. And so one list may have your handwriting, the other list may not have your handwriting. So you have to actually type it and print it, and all lists in the theater have to be changed. That is clearly mentioned. Any addition that you make to a list has to be agreed by all staff. Everybody has to agree that you're going to do an extra patient. You cannot just put somebody on the list. Most important is remove old list when a new list is published. Very biggest mistake that people do is they don't remove all the old list, and then errors happen. So very important, remove old list when new list is published. The list should be clearly displayed in the OR. Very, very, very important. And the list should be reviewed. So there must be a system in the organization where you review a elective list 6 weeks, 4 weeks, and 2 weeks prior, but all lists should be reviewed 3 p.m. before the day of the surgery. Very important that the list is reviewed to make sure that the correct patient is on there and you don't waste theater time and the staff time. And there's a lockdown, usually 3 p.m. the day before is a lockdown. Everything else beyond that, then you have to, there's a process that you have to go through to add somebody to the list. Okay, is that clear so far? The list is very important. You have to be able to tell me. In an exam, I might ask you, how do you make a list? Okay, and some of these points might come up. Okay, handover and transfer information is again important. You have to optimize patient handover and optimize patient care. So this is the guidelines that are there, very clearly stated. So handover has to be verbal or written. Okay, only handover person should speak when the handover is happening. Nobody else should talk, but everybody is allowed to ask questions. So there is something called as voice silence. So when somebody is handing over, one person should talk, everybody should be quiet, but anybody can ask a question which is clinical related to the patient. There is a ward to the procedure team, which means when the patient, the incoming team. So when the nurse brings the patient into the ward, it is very clearly decided. There is a ward nurse, anesthetist, and surgeon should be present in the anesthetic room when a ward to the procedure team hands over the patient for operation. So this is a mandatory requirement in the law. The documents that have to come in the transfer are peri-op chart, care plan, all of them dated and signed, the wristband, drug chart, and WHO checklist. This has to be mandatorily mentioned in all of this, okay? All right. During procedural care, procedure team to post-procedural area, or procedure and procedural area to ICU. So these are the 3 areas where you have to do an official handover, okay? So when the patient comes in, when he goes out to the recovery area, and from there, when he goes out to the ICU or the ward. So it's very, very clearly documented that handover has to be done at all 3 areas. Okay, is it clear? Did it make sense, or is it too much?
Yes, sir.
It is quite important. Okay,
Very
induction,
important.
dedicated time, dedicated staff, structure and comprehension. So very clear-cut guidelines on how the induction should happen for new staff. Okay, so there should always be a local invasive induction mandatory. Anybody who's doing procedures in theaters or whatever has to undergo a local induction protocol. The induction pack must be sent before the start date, not on 2 days after he has started job. It has to be sent before the start date. It has to be prioritized. The induction, you've got to have dedicated timing, dedicated staffing, and a dedicated space for it. Nobody should start working and then have induction 1 week later. That is not allowed according to the law. You must have named speakers who are going to do the induction. So it has to be organized, structured, and comprehensive. And all staff members have to be included, including the GDA, including the cleaning person, including doctors, including nurses. Everybody has to undergo a mandatory induction process before you start. MDT team is very important. A team of expert is not an expert team. This is very good philosophy. Remember this, it is not just what we did, but how well we did it. And so this is the MDT standards that they have put into place. The MDT standards are that MDT team has to be trained before they sit in an MDT. They must know what is their role, how they're supposed to participate in the MDT. It's always got to be multi-professional group. It's got to be planned and delivered on a rolling basis. So fixed time, fixed date should be decided for every MDT. It must involve all the safety practices and must include non-technical and human factors as well when you're deciding MDTs. And regular updates and continuing professional development is mandatory for an MDT. Now, these are all organizational responsibilities. Okay, so this is what an organization is supposed to do. Now, what about the local responsibility? How do we look at local responsibility? So this is the sequential. So the first one was organizational, where the organization is responsible for making sure all this is in place. Now we come to what we as clinicians are required, okay? So this is called as LOCSIPs, local safety procedures, okay? So let's look at the LOCSIPs now. So procedural verification of site marking, okay, very clearly defined. Correct procedure on the correct site and site, okay, that's what they say. So let's look at what it talks about. You have to verify the mark. The mark has to be done on the ward. Mark has to be done by the operator. He can delegate to a person who is of equal level, not by the nurse. The nurse is not allowed to mark. It has to be a doctor. It has to be a team member. You must use a permanent marker. If it's an infected patient, do not use that marker on other patients. It should be a single-use marker when you're dealing with infected or TB patients or whatever. You should throw that marker away. If you're using any teeth notation, then there is something called as a PAMA notation. So if you want to say that teeth 4, 5, 6 molar are shaky, then there is, if you look up PAMA notation, it's very clearly defined. There's a way how you draw a cross across, and upper jaw, lower jaw, it's all, there's a way of notation teeth. So teeth, if you want to talk about anything about teeth, you have to use the Palmer notation, okay? And that Palmer notation should be mentioned on the whiteboard, consent form, and checklist, okay? Google Palmer notation and you'll see it's just a diagram of the teeth, upper and lower, and each teeth has a number attached to it. So that is called as a Palmer notation. The most important thing is you got to check the mark, okay? Check the mark before you start doing anything. Very, very, very important, okay? So this is part of LOCSIP. Checking the mark is so important that it has been put as the first point in the guideline, okay? Very important. Team brief is a very important part of LOCSIP. You cannot start a theater list without having a team brief. So briefing opens communication channels to plan and assure safe care. That is the philosophy, okay? They write it at the top, and then these are the team brief points. Everybody has to introduce the team and everyone. This is before the start of the operating day, okay? So in the UK, 7:30, I have a departmental meeting where we discuss the day's whole theater list, including cardiac and thoracic and use of resources, ICU beds available, etc. 7:45, everybody comes into the anesthetic room and everybody is supposed to be part of the team. You cannot start a team brief till all members are present, including the junior registrar, including the SHO, including the circulating nurse, including the GD. Everybody has to be present and everybody has to introduce themselves and everybody else, okay? Mandatory. All team members have to be present. We cannot do a team brief we cannot sign off a team brief till everybody is present. Brief has to be at an agreed time. So we do it 7:45. Silent focus, most important, no talking during briefing. Very important. This is very often people are chatting away. You're not allowed to do that. Each patient on the list should be discussed. At least at the start of the day, you must discuss what is needed for each patient. You have to share vital information. Like, you know, this patient may need to go to ICU, this patient may need to go to HDU, this patient has got a pacemaker in it, so we will be using bipolar diathermy, things like that. Vital information has to be discussed. And you have to keep a record of everything that you said. So all of this is ticked off. We all have a form actually in a team brief, and we keep ticking off as each one of this happens. And any issues are identified, you must report it and take action on it, okay? Very, very important. The team brief will make the rest of the day very safe. Sign in. That's the next step, okay? This is the final gatekeeper of invasive safety checks. Very important. And everything is neatly laid out. Now, I'm going to go through each one of them. All patients have to sign in. There is no two ways about it. Sign in has to happen before sedation or anesthesia. You cannot just induce the patient and then say, let's do sign in, okay? Sign in is always two-person check. So one person reads out, the other person checks, okay? Very important. You have to make provision for language of the patient. If the patient is not able to speak the language, then you get an interpreter in the sign-in. You should not start the case till somebody is there who talks the language of the patient. And safety check has to be done with signature. Everybody, whoever does it, has to sign against the safety check to say that we have done it, okay? So what are the safety checks with signature that you need to do? You need to do anesthetic checks. You need to do emergency equipment checks. So the emergency trolley has to be checked. Paperwork has to be checked, which includes notes, consent, drug chart, venothrombo prophylaxis, allergy, so DVT prophylaxis, allergy status. All of this has to be there, and you have to sign a check. Consent form check, surgical site marking check, pregnancy status of the patient. Allergies have to be clearly documented. The starvation time and the aspiration risk has to be clearly documented and checked. Potential airway problems have to be checked. You have to say whether you think it is grade 3 intubation, you expect a grade 3 or a grade 1 intubation. You have to say that loud and somebody has to check it. Infection risk of the patient has to be checked. Arrangement for blood loss has to be checked. Availability of all essential equipment and implants. So if you're going to use a mesh for a thing, you have to write there that the meshes are available in theater of this size to that size, and then somebody signs against it. Essential equipment. If you need a harmonic, you have to check that the harmonic is there in theater, okay? And if you do need additional staff, like if you need a cardiopulmonary bypass, you have to check that the additional staff is available, all right? So very important. Or if you need 2 assistants in theater, you have to check that before. This is all even before you started the case, okay? All right. So timeout. Timeout is very important for the final safety check before the cut. Timeout is not at the end of the operation. Timeout is just before you're starting the cut, before you're starting the operation, okay? So timeout is, you have to check immediately before the procedure. Very important. There must be silent focus. Nobody should talk during a timeout. Very, very important. Any team member can lead. It doesn't have to be the circulating nurse. Anybody can lead. You have to introduce yourself. All team members have to be present for timeout. Encourage patient if awake, which means if you're doing it under local anesthesia, Then involve the patient in the timeout as well, okay? Declare the timeout is complete, okay, whenever you complete it. What are the contents of a timeout? Patient's name, name band check, the surgeon, the anesthesia, the scrub practitioner, or the operator's assistant, both have to say, the antibiotic prophylaxis that is given, the time it was given, whether patient warming is on or off, whether the glycemic control of the patient is adequate or not, has hair removal been done or do you need to do hair removal, and DVT prophylaxis, allergies, infections, and pregnancy status. These are the words you have to use before you can sign off the form for timeout, okay? It is mandatory, and we do it for every case. Everything that I've said so far, we do every day for every case. There is no way out of it. There is no shortcut. And that is how you prevent accidents from happening in theater. So you might think that it's such a long thing and so on, but we do it every day. And we do it for every case, every single case we do all of this. So it is mandatory. So it becomes second nature for all of us to do this. And that is what you have to practice, okay? Now there is SPI are very important. Stent, prosthesis, and implant check is a separate document altogether. Artificial implants matter, right size, right process every time. That is the key, okay? So that's the pathway for that. I'll just talk about it. The permanent internal, external medical devices have to be documented. Preoperative SPI requirement is mandatory, which includes stock of an SPI. SPI sign in, any SPI that comes in has to be signed in. You have to know what has come into the theater. And you have to check that it is for the correct surgical placement, okay? Very important. That check has to be done. You're not putting the wrong prosthesis in the wrong patient for the wrong operation. So that check is done and it has to be signed. Everything that I'm saying has to be signed. The product type, design, style, or material is clearly documented. The size is documented. The correct size and the laterality, whether left or right, is documented. The manufacturer is documented. Expiry date is documented. The sterility of the prosthesis. The compatibility of multi-component documents, of multi-component devices. So you may have two separate components, you know, a ball and a socket. So you have to use the correct one for the correct one. You cannot have a mismatched device. And any other specific characteristics of that SPI is documented. Any deleterious effects of an incorrect SPI, if you put in a wrong prosthesis or you have to throw away one prosthesis, you have to document what was the problem with it. Patient factors have to be documented. Was there mortality, morbidity, any further procedures needed to be done? Did you using a wrong prosthesis result in a substandard clinical outcome? Financial cost of the SPIs has to be documented. So discarded SPIs, the medico-legal case, cancelled case, all of this are huge impact. And all of this is looked at when we look at SPI audit. SPI sign out is done before you finish the operation. So labels are checked and they are stuck to the notes. They are added to the computers and added to the registers. There are various registers available for various things. You have to make sure that the SPI gets signed out, okay? Now, sometimes you do have retained foreign objects. Nothing left behind that was not intended, okay? That's the philosophy of this document. So it is the organization's responsibility for any retained foreign object and the surgeon's responsibility. The equipment has to be correctly managed. During procedure, the count has to be done by 2 trained staff, mandatory. This is all written down, okay? There has to be a baseline count before you start the operation. Before closure of any cavity, before closure of any major organ or closure of the abdomen, the count has to be done. If you're going to close the pericardium or the pleura, the count has to be done. Or before wound closure, the count has to be done. Okay, these are the various things very clearly placed out. Or when skin closure begins. So at each one of these stages, depending on what operation you're doing, you have to have a countdown done. Also, when a nurse changes over, a new nurse comes in, the handover, there has to be a count done, mandatory. Okay. Most important thing is focus without distraction. Nobody should be talking when a countdown happens. Very, very, very important. Okay. Pause for gauze is what they say before the final countdown. Very, very, very important. And what you're looking for is instruments, swabs, sharps, disposables, and packs. So these are the things that you really need to count down. So what happens if you've lost a failed reconciliation means what happens if your countdown is not correct? What is the action to take? Inform surgeon, repeat count, operative site search, X-ray, document whatever happened. Even if you found the instrument afterwards, that event should be documented. You must report to a theater coordinator. An incident form has to be filled in for every failed reconciliation. And most importantly, you have to provide information to the patient. Okay, this is very, very important. You have to provide information to the patient. Okay, sometimes you deliberately leave things behind, like packs. All packs should have pink band. There should be a red color thread with the pack. There should be a sticker which tells you what's gone back in there. The patient leaflet, it should be mentioned in the patient leaflet that you've put a thing back. All documentation should be clear. It should be mentioned in the handover that 3 packs are left in the chest. The patient's information has to be mentioned with the pack. So whatever sticker you put in the patient, you have to stick a patient's information along with it. More importantly, the plan for future care. What are you going to do with those retained packs, those intestinal packs? So plan for removal has to be very clearly documented. Okay. So sometimes in the exam, we ask you, what do you do? What are the protocols for when you leave a pack behind in the chest? And this is the answer for it. This slide is the answer. Similarly, for the previous slide as well, sometimes if what do you do if you found that your scrub count was not adequate? Okay, or your count was not correct. So this is the answer. We have to go in this order and say all of these points. Okay, that's why I put it in the way I put it, just for you to be able to recreate it back in the exam. So the top is the question and the bottom is the answer. So what do you do in a sign out? Pause for gauze. That's what they say. Pause for gauze. So essential safety checks have to be done, announced loudly. All team members have to be present. Silent focus. Nobody should be talking. Any team member may lead. Surgeon verbally confirms procedure site and side. Scrub nurse confirms instrument count, retained packs, and specimen labeled correctly. The recovery and the management plan is discussed. Blood loss is discussed. Drains, plan for the drains, any clamps that have been applied to the drains, and discharge plan from recovery or discharge back to the ward is discussed in a sign out. So keep the patient in the recovery for 4 hours, make sure that he is adequately conscious, start oral feeds, etc. Send to the ward back at the end of 4 hours. That is called a sign out. Okay. Equipment issue is clearly discussed. If you had some problems in theater, you must discuss it. Operation notes are done and put into place. So you cannot do sign out without the operation note having completed. I've seen many times people doing sign outs and doing operation notes 2 hours later, or going for a cup of tea, coming back. Actually, operation notes are part of sign out. You cannot sign out till the operation note is handed to the nurse. Okay. So you are supposed to do the operation notes immediately, not 2 hours later. And location of relatives is discussed in the sign out, because you need to call them and tell them about the operation. So this is, again, very clearly the strategy is laid out. And this is from the document from the government. Okay, this is not my document. So all of this answers, all of these questions have a very clear-cut answer. And we don't want you to, faff around and give me relatives first and recovery last. Okay, we want you to give me in the order that it has been presented by the government. Okay, debrief, that's very important, part of lockstep. Okay, what went well, what not so well, and how can we improve? That's the concept of debrief. Again, these are the points, and I'll go through each one of them with you. It's essential for team communication. Whole team is involved in a debrief. It's usually done at the end of the day. Can occur during the list or can occur at the end of the list. Okay, so you can do it case by case debrief, or you can do it at the end of the day debrief. Both are allowed. Job planning should include debrief, which means if you are contracted for 8 hours a day, then debrief should be included in that job planning. Okay, you cannot just say that every day you're staying over late to do a debrief. That's not allowed. The organization has to pay you for staying back for doing debrief. Okay, things that went well have to be discussed. Any problems that happened during the operation has to be discussed. Any areas for improvement have to be discussed. What the team can change has to be discussed. And most importantly, you have to decide who will lead on the feedback at the next team brief. Okay, because you can talk of all of these, but until and unless it is implemented and you get a feedback that this is what we said in that day and this is the action that took place, it is meaningless. So you have to make sure that there is feedback at the next meeting to what action was taken when the debrief happened. Debrief log is kept, so everybody records everything that you're doing. Problems and issues are identified. Action is taken to resolve the issue. Most important is action. Don't just identify the problem. You have to take action to resolve the issue. Person leading on the action has to be decided in the debrief. You, so-and-so, will report this to so-and-so, and this is the action you will take. This is how you have to record it. The time frame for action has to be recorded. So you have to do it today, tomorrow, whatever. The time frame has to be done. And debrief should be available and shared with everybody. You cannot keep it confidential. It is actually meant, if there's something has gone wrong and you've identified a problem, those records should be available to everybody to see so that they can learn from it. And local governance issues have to be identified and communicated to the governance managers who are there. Okay, so very important. Debrief is absolutely vital. Okay, so when you do this, Atul Gawande has written a beautiful book called as the Checklist Manifesto. It talks about how to get things right. And everything that I spoke today, NatSip and LockSip. If you follow the NatSip and LockSip, and we follow it every day, every single point that I spoke today, we follow it. There is nothing that we do not follow. In fact, if we do not follow, we get reported. I promise you that. If I'm not there at 7:45 for the team brief, I will get reported to the organization, and action can be taken against me. So it is mandatory. It's just, there is no way you cannot not do the NatSip and the LockSip. So if you do that, then these things will not happen. Complications will not happen. Okay, and these sort of papers will not come out. It's absolutely mandatory. Today's topic was extremely boring for you. It might be very exhaustive for you. You might think that, oh, I do this every day, I don't need to know it. But actually, until and unless it's put into paper and it's put point wise, you do not realize how many things you're missing out and how you are putting your surgical life at risk. It's not worth it. It's just one mistake can completely destroy your surgical career. I know many surgeons who are sitting at home because they didn't do the brief correctly, and they operated on the wrong side by mistake or the wrong lobe. It's a disaster to happen. Okay, thank you. Okay, that is for next time. Okay, where are we? Stop share. Okay, I'm very sorry. It was a very exhaustive talk, but you will not realize that of all the 50 talks, this is 51st talk. This is the 51st talk, by the way. Yesterday was 50. Wow. Of all the talks, the 51st talk was the most important. I promise you this.
Yes, sir.
You have no idea, but actually,
yes, I agree.
Yes,
the most important talk.
Yeah.
And everything I have given it to you on a platter. I spoon-fed you. I spoon-fed you, but please use it for your clinical practice. I would somehow get these slides and keep it with me. I don't care how you get it. Or you download, Google, NatSip, LogSip. Okay, and download these documents. They are very important, and follow it every day. I follow it every day, every case. Not every day, every case. I promise you. Medanta is very good at this, I have to say. At least when I work in Medanta, Bhushan and Nikhil will tell you that I think we follow every single one of these. There are no shortcuts. And that is why I come to Medanta and I feel comfortable operating in Medanta. And I feel very uncomfortable operating in a small place. One day I was invited to operate in a small place. Out of goodness of heart, I went there and they induced the patient. And I came in after that, they induced the patient, everything was done. And I said, guys, let us see the consent. And there was no consent. There was no consent. There was no consent for the patient. The patient was under general anesthesia. And I refused to operate. I said, I'm not operating. I told the local guy, you operate, I'll guide you. I don't want to do this case. I am not taking responsibility for consent. But a small place, they had invited me and I went in goodness of heart. I said, let me go and help them. But after that, I said, never again will I operate in a small place. Never again. Because one mistake you make, your career is gone, man. I mean, you have no choice. The responsibility, unfortunately, ends with the surgeon. All of this that I told you, every single shift that happens, the responsibility is yours. I'll tell you, you have one medical legal case against you, you lose sleep for months together, months. And it takes you at least 300 to 400 papers to read and to write a report on a medical legal case. I promise you this. At least 300 to 400 pages of literature you have to read and you have to write. And then the solicitors give you hell over that as well. So if you follow these guidelines, this problem will not happen. That is what I'm trying to tell you. Okay, now one of you just take the chat questions and ask me. I don't want to read it. I'm too tired now. So just somebody ask me the chat questions if there are any. And I'm quite happy. Take it, Shilpa or Vikas, take it.
Yeah, okay. Okay. So Adnan is asking if attendants don't want to share cancer news with patient and request if stages 1 and 2 you're operating, then you share information.
Not allowed. By law, you're not allowed. You're doing illegal.
Okay. Okay.
If something goes wrong in a court of law, you will be held liable. You're not allowed to not share information.
Don't share this first. Okay.
It's the patient's right to know that he has got cancer, no matter what the relatives say.
Yeah.
So you don't use the word cancer. You can use the word tumor. You can use the word nodule. There's something, but you have to tell the patient. You have to tell the patient. You're not allowed. You don't have to use the word malignancy. Do you know what I mean?
Yeah.
You use a different word, but you have to tell the patient. So not allowed. By law, you are liable. Full stop. It's very clear.
Okay. Andrew is asking, are advance directive and living will same things?
Yeah. Advanced directives and living wills are more or less the similar things.
Same thing. Okay.
Yeah, I'm not a lawyer, but the interpretation is the same. I'm sure there must be subtle differences in law, but the interpretation is the same. That they are to be followed.
Okay, he's asking again.
But very good point, actually. Advanced directives and living wills are important things. You must know about them. Yeah.
So he's also asking, retained swap, how liable is a scrub nurse who is supposed to maintain counts at all times?
Yeah, but the responsibility is the surgeon's. In the court of law, you will go to jail. Scrub nurse will be liable and all that. They will take action. But at the end of the day, she gave you wrong information. Whatever happened, eventually it is your responsibility. Full stop.
So now
or your organization. So it is very important.
Right.
Okay, someone is asking, what is the validity for a consent? I don't know what that question is.
Yeah. That within 24 hours, you should have done it again. That is the bottom line. So you cannot do it 1 week before and then expect to, have it valid. Most organizations say within 24 hours.
Okay. So another.
Yeah, 1 minute. Nikhil is asking something about that.
It's a 24-hour or 1 day prior.
It's one of the same.
Yeah, I don't know. 1 day prior, but within 24 hours is what most people say.
Okay. Then another surgeon is asking, what if attenders ask not to inform patient that he needs early CABG or any other procedure? They themselves will inform the patient. Then in that scenario, what will
then you should not take responsibility for such a patient. If you are going to operate on the patient, you have to inform the patient. It is not the attendance. You are not, when you consult a patient, you consult a patient, not the relatives. Do you understand? So the contract is between the patient and you, not between the relatives and you. So it doesn't matter what the relatives say. The patient has to be involved in the discussion. I will never send a patient outside the room. Never.
Okay.
In any discussion I have, these guys will vouch for it. I mean, over the years, relatives say, sir, isko jara bahar bita dete. I will never send the patient out of the room. Never. And in fact, you know, they go out and then one person comes back in afterwards. And I strongly discourage that, because that means the patient will think you're hiding something and going to tell the relative something else afterwards. So I do not encourage that behavior. If you want to ask in front of the patient.
Right. So another surgeon is asking, is left gauze piece a collective responsibility?
Surgeon's responsibility. Full stop. Court of law. In a court of law, it is the surgeon's responsibility.
So if two consultants have operated.
Yeah.
The patient under whom the patient is admitted. The surgeon under whoever, there's always one lead surgeon. So if the patient is admitted under your care, it's your responsibility. Even if somebody else did whatever they did, if your registrar did the case and left a gauze behind, you are liable. It's very clear. The law is very clear on that. That's why, you know, being a surgeon is not an easy job. You are taking responsibility for all the shit around you. So you have to be like a pilot. And that is why these guidelines are very important, because if you put these up in the theater and follow them point by point, then you are less likely to make mistakes. That is why JCI accreditation is important. And all these guidelines which I've shown you are on paper, pen and paper. They are on paper and they are stuck up, or they are put into the notes of the patient. So you follow everything one after the other, one after the other, one after the other. So there is less chance of you making a mistake. If you go haphazardly, do team debrief before sign out, you will make a mistake. So that's why it's important to follow the pathway that I have just described. This lecture is crucial. You have no idea how much you'll thank me for 20 years down the road for telling you all these things.
Yeah. So someone is asking, if complication or death occurs, it is to be informed to indemnity insurers?
Your job is not to inform the insurers. Your job is to inform the relatives.
Okay. Then is high risk any different from standard consent?
Some hospitals have the concept of high risk consent, but within the law, a consent is a consent, and all consent should be treated as high risk consents. But some hospitals in the JCI world have what is called as a high risk consent. The problem is, how do you define what is high risk? Okay, so that is why GNC talks of only consent. It says, so there is no cutoff point for that. You see, it's very difficult to have a cutoff point. But yes, some hospitals have what is called as a high risk consent. So you have a consent and then you have a high risk consent. But really, my practice is all consents are the same. If it is got high risk, I tell the patient they're a high risk very clearly. And more importantly, I document on the consent form that it is high risk procedure.
Okay. Someone is asking, post-operatively, till patient becomes conscious enough to give consent, which relative's consent is most valid? And what if that particular relative is not there?
No relative's consent is valid. Full stop.
At least in UK, it's not valid.
No. Even in India, more so.
But in India, they give.
Is even worse. No, it is even worse in India. I'll tell you, the relatives try to push their way forward, but if that goes to court, no legal validity. The relative's consent has no legal validity. I'll give you an example of a patient who had a something DNC or something was happening.
No, that case I remember. I know, sir.
Or do you know that?
She had given consent for oophorectomy. Oophorectomy, because she had ovarian tumor. and they found something is with the wrong with the uterus also. So they went ahead and removed the uterus also. She showed that if you had removed only the ovary, I could have gone got a donor transplant, donor pregnancy or something.
No. That was not the point. She had given the consent for oophorectomy, I know. But they decided, they went out and spoke to the mother.
Asked the mother. Yes, mother.
They asked the mother, and the mother gave consent for hysterectomy.
Yes.
And then the patient sued the surgeon saying, my mother cannot consent for
decide for me.
Yes.
So it is very clear. Relatives cannot give you consent, full stop. No matter what, you have to put your foot down. You know, you have to put your foot down saying you cannot give consent. Okay, next.
Okay, yeah. So someone is, I don't know if he's asking or informing, but okay.
Let her finish the questions and then you can ask each one.
Yeah. So somebody's saying expected surgical site infections are also liable to get sued in court. I don't know if he's asking or informing.
No, yeah. People can sue you for anything, man.
Anything.
Whether they win or not is different, but they can sue you for anything.
Should you be involved in filling up insurance claim forms for the patient on his request? In India, it's a big problem.
Insurance claim forms, what do you mean by that? I mean, do you mean should you countersign the insurance claim forms? That is your legal
they ask you to fill it.
Yeah, you have to do that. That is requirement of your job. That if a patient has got insurance and that needs a medical certification, then you have to fill that section and you have to sign that section. Because remember, in consent, we spoke about costs. You know, it's part of consent. Costs is part of consent. So if a patient needs your signature to get his insurance, then it's your legal responsibility to fill that section. You are required to fill that section. That's what the law states.
A lot of paperwork.
Yeah,
yes.
but you chose to be a doctor, you chose to be a surgeon, and then you can charge 3 lakhs per case or 10 lakhs per case.
Yeah, for that.
Okay. Thank you.
So someone is
there is something called as insurance handling charges charged by the hospital.
Whatever that is, whatever way they do it, but you have to do what you have to do. Yeah, go on. Shilpa, finish the questions.
Yes. Mostly specialties will have consents specific to that particular specialty. Is it a problem?
That's okay. That's as long as the hospital has approved it. That's okay. That's allowed actually.
If patient comes,
but the recommendation in a hospital is to have standardized documentation across the board, so that the patient's journey is smooth from one department to another. But specialties do have special consents.
Okay. If patient comes unconscious, if we want to take for emergency surgery, then from whom we should take consent?
Two clinicians can give a consent. 2 clinicians of equal ranking can give a consent, or 1 clinician and 1 medical superintendent can give a consent. Or if you don't have, then you got to take the court, the magistrate can give you a consent.
Okay. Second part of this question was, what about if hospitals using already printed format for consent? I don't know what that.
Yeah, but the printed format should be a standard format which has area for free text. So you cannot use a pre-printed saying hernia written and all that. That is actually not allowed. Pre-printed is not allowed. Procedure you have to write, because every procedure is different for every patient, and complications you have to write. These 2 things, and the patient's name, patient signature, and the person taking consent and his signature. These 4 things have to be written.
Post-op, if IVP or ECMO is required for the patient, can his or her relatives deny it due to financial constraints? Because ultimately relatives have to pay for it if the patient doesn't survive.
Yeah, but that is a very, the relatives cannot deny anything. Relatives have no role in this. I'm telling you. It's very clear cut. Relatives have no role in this. And in fact, you are liable. Financial cost is put to one side, but if you felt that you could save the patient's life by using an ECMO or by putting in an IBP, you are obliged to put in an IBP. Because if it goes in court and an expert from the opposite side says, but you should have put in IBP, what will you say? That I didn't put in because there was no money, there was no payment available? How will you justify that? Because they are also going to get experts, and they will get cardiac surgeons who will tell them that this patient would have been alive if he had had an IBP. So that's how you have to think. So you have to actually, finance doesn't come in this. You cannot take clinical decisions on the basis of finance. What you do in real life is different, but in a court of law, they are horrible to you. Nobody can, you cannot stand up in a court of law with the finance as a answer.
Okay. Blocked grafts within a month after CABG, is surgeon liable?
I don't know about that. I don't know about that. I think not. I think not is the answer, but I don't know the specific details. I don't know.
Is there a classification of complications, common, uncommon, rare, depending upon percentage?
Yeah. There is. If you look it up, it is there. All complications for your specialty, the average. What you have to look for is, in India, we don't have it, unfortunately, but in the UK, we have what is called as a blue book, where all units publish their data. So when units publish their data, you can use any one of those as a national average. So we have every year a document come out, which gives us a national average. So, for a CABG, it's 1%. For a lobectomy, it's 1 to 2%. For a pneumonectomy, it's 5 to 7%. This is a national average, which comes from the blue book or the silver book, depending on which specialty. In India, unfortunately, you don't have it. So you use international guidelines. You can do that.
Okay. Yeah, the questions in the chats are finished.
Sometimes we write in consent, aortic valve mitral valve replacement plus minus aortic valve replacement, because we don't know whether we need to operate. It will be decided after the TE.
Yeah, plus or minus
is that a valid
allowed.
form?
Yeah, that is
allowed.
valid. You are valid, because that is, you are discussing further procedures. That is allowed. Like we do, when we write lung resection plus minus decortication plus minus whatever else, because actually that is good practice. You're discussing everything with the patient and writing all possible outcomes. But the one thing in the exam which I want all of you to say is also including no treatment given. That is, a lot of people don't say it. When you discuss consent, you have to say what is going to happen to the patient if no treatment was given, and that was discussed with the patient. That's what you have to say. Very important.
Okay. So we have a couple of questions more. Do we need to take the consent prior for converting VATS to open thoracotomy, or
that should have been discussed? No. That is actually discussed pre-op. There has to be, on the consent form, you have to write VATS plus minus open thoracotomy. If the patient has refused to give you open thoracotomy consent, then open thoracotomy is only for life-saving, like bleeding. But just because you couldn't get a tumor out, you cannot do it. You cannot convert VATS to open. So our consent form always, no matter how minor the procedure, we write VATS plus minus open. So we write robotic plus minus VATS plus minus open. Always take a wider consent. Take a wide consent so that you can do everything possible on table. But if the patient has refused open thoracotomy, I would actually refuse surgery. I do not do a VATS when the patient tells me you cannot open my chest. I refuse the patient and I say, sorry, I cannot take that responsibility. Because if something goes wrong, I might have to convert VATS to open. There's a 2% chance, there's a 1% chance, but still there is a chance. So if you do not sign the consent saying VATS plus minus open, I will not operate on it. That's my practice. Somebody's phone is making too much noise.
Yeah, because I think it's yours.
I don't know.
I want to ask some questions.
Okay.
If suppose we are refusing a procedure or a surgery, are we obliged to tell him to seek second opinion? Like one of my friends is stuck. He refused a CABG thinking the vessels are very poor. But he did not write the patient may seek a second opinion. Now he has gone to some other surgeon and he said, okay, we can operate. So he says, I lost valuable time. So every OPD prescription, suppose I think that vessel is very thin, it is not likely to be. So I am supposed to write that he is supposed to seek second opinion. I don't think
you are supposed to write, but you are supposed to discuss with the patient that, you're free to seek a second opinion. In my practice, I always tell the patient, take a second opinion.
Then the last question on the chat. The surgeon doing freelancing surgeries and then they leave the hospital, patient dies later, can he be sued?
Yes, he can be sued because the responsibility is the surgeon.
Of the surgeon.
Yeah, the person who is operated, his responsibility, full stop.
Yeah, okay, the questions are over.
Okay, thank you very much, guys. This
I
has
have a
been
couple of questions.
One
I have a
minute, let
couple
me
of questions.
stop the recording.
Yeah.